My name's Cameron Kaufman, and I'm the president of the Buckley program. I'd like to welcome you to our event today, Drug Pricing and Cost Transparency, Addressing America's Healthcare Crisis, with Senator Tom Coburn. And before I introduce Senator Coburn, I'd like to make a couple quick announcements. Firstly, for those of you who don't know, the Buckley program is an organization dedicated to increasing free speech and intellectual diversity on campus. And we do so in a variety of ways, including hosting dinner seminars, lectures, firing line debates, and an annual conference. You can learn more about our program on our website, buckleyprogram.com. And secondly, this is our penultimate event of the semester. Our final event of the semester is going to be this upcoming Thursday at 4:30 p.m., a firing line debate on public sector unions. And that debate will be featuring an expert from the Manhattan Institute and an expert from Columbia University. I encourage you to come by. It's going to be a really substantive debate. Our two experts really disagree, so it should be very interesting to listen to, and it's an important topic. And now, on to Senator Coburn. Dr. Tom Coburn was the U.S. Senator for the state of Oklahoma from 2005 to 2015, serving 2 terms. In the Senate, he was the ranking member of the Committee on Homeland Security, and he also served on the committees on Banking, Housing, and Urban Affairs, Health, Education, Labor, and Pensions, and Intelligence. Before serving in the Senate, he served as the congressman for Oklahoma's 2nd Congressional District from 1995 to 2001. And now, Dr. Coburn is the Nick O'Neill Fellow at the Manhattan Institute, and an advisor to their project on reforming the FDA. His Manhattan Institute work is bolstered by the fact that he's a family physician and even saw patients while he served in Congress. So we're honored to have someone with tremendous experience in both the medical world and the political world here to talk about a topic that was very important in the past midterm elections and is pressing many people in our nation. So please join me in welcoming former Oklahoma Senator Tom Coburn to Yale.
Thanks, Cameron. Appreciate it. Well, I'm going to make this kind of a back and forth, just visit, if I may. What he didn't say, during my 6 years in the House, I delivered 450 babies. But the Senate kind of put a stop to that after I blocked the bridge to nowhere. And so the Ethics Committee came after me for delivering babies, saying that was a conflict of interest and being a U.S. Senator. It's a pleasure to be here. I've been here before, not to this group, but to others. I kind of want to broaden the topic a little bit, not just to prescription drugs and healthcare, but to healthcare in general. Because what we know of 4 recent studies that healthcare consumes 20 to 22% of our GDP, highest of anywhere in the Western world. But we also know that 1/3 of that doesn't help anybody get well and doesn't prevent anybody from getting sick. So we ought to ask the question, how do we fix that? Should you be able to know 88.8% of the time what something's going to cost you before you buy it in healthcare? And I think the answer to that is yes. The other 1.2%, 10.2% of the time is related to emergent care or mental health care. So almost 90% of the time we're buying something without the knowledge of what that's going to cost. And there's a lot of reasons for that. But what it has is created a system that's highly inefficient and has no price transparency and no market forces that allocate it. And I think if we actually we want everybody to have health care. And there's all sorts of ways to try to fix that. There's 2 ways that I see that are going to happen to us. We're either going to go to completely government-run health care, or we're going to go to a market-based, transparent system where you can see outcome and you can see price. And so the question I have for you is, should we incentivize excellence in healthcare? Because the system we have today doesn't. It doesn't incentivize excellence. Because we don't pay the doctor that has no complications when they do a bypass surgery or put stents in the heart more than we pay the doctor that has a complication rate of 5 or 10% of the time. And now with the hospitals owning most of the physician practices, we have this conflict of interest against the oath that they take to refer to doctors that are on their team, even when those doctors aren't the best doctors. And so then we economically punish physicians or caregivers by saying, if you refer outside of our system, we're going to cut your pay. And so all of a sudden we have the attempt, and this is not judging anybody's motivation. Everybody wants people to get good health care at an affordable price and nobody to fall through the cracks. I don't think anybody disagrees with that. The question is how can we most efficiently do it? And so I think what we're doing today is the worst of both worlds. Because you can't see trends. And I'm a 3-time cancer survivor. I also have a cell phone that I didn't turn off. Pardon me. I'm a 3-time cancer survivor. And I'm having trouble. I'm on a medicine now that costs $2,800 every 3 weeks. But I had to go and dig to find out what it really cost. Its list price is $8,000. But I had to go and find that out. So how do we solve this problem, which is actually a problem of young people? It's not a problem of old people, because part of our unfunded liabilities of $144 trillion right now, the vast majority of that's going to fall on the young people in this room. Not the people who are actually consuming the benefits from it, but you. If you take our unfunded liabilities, you take the millennial generation, and you divide it out, what's going to happen is for the rest of your life, you're going to be paying an extra $30,000 because my generation wasn't competent enough to do the right things at the right time to not mortgage your future. So I actually believe in markets. And I know markets aren't perfect. And I actually know some people will fall through the cracks if we had a market-based system. The question is who's falling through the cracks now, and what is the cost for them falling through the cracks versus what would be the cost if we had a true market-based system. So the question I would ask for you to think about is, why would you buy health care not knowing outcome and price before you buy it if it's non-emergent? And the reason is you're incentivized not to, because you know what your deductible is, and you know what your copay is, so that's your limitation, and so you're not incentivized. So if we had a system where price transparency was available and you had skin in the game to make a difference with that, would healthcare costs go down? And let me just give you a little example. There's a app in Oklahoma now called Medisys. And Medisys markets to companies that have ERISA-based plans, corporate plans for healthcare. They're self-funded. And so what they do is they go in and mine the data, and then they go around all of Oklahoma and find out what things cost, the best price. Then they put it all together, and the ERISA plan, I know one company that's saving $250,000 a month on outpatient testing. And what they do to their employees, they say, you can go get this done where your doctor wants you to get it done, but we'll pay your copay and your deductible and give you $100 if you'll go get it done over here. Same outcome. And I'm talking testing. I'm not talking procedures. I'm talking testing. And so this one company that has about 4,000 employees is saving about $250,000 a month just by buying smart based on what price is. Well, what would happen if all of a sudden there was a mandate that no longer in the healthcare industry can you hide behind not having your prices or your outcomes out there? So that you as a consumer, you could actually know what something costs before you buy it. What would happen? Well, the estimates are that we'd cut the first year $400 billion out of our healthcare bill. $400 billion. $400 billion is enough to educate a ton of people at the college level, right? Our student loan bill, what is taken out in student loans each year is about $600 billion. So you could take that $400 billion that we're not helping anybody with, that's paid out by the government, and actually make a big difference in terms of higher education in our country. You could make a big difference in terms of our deficits that you're going to have to be paying. That is going to be paid back. And you're going to pay it back one way or the other. You're actually going to pay it out, or you're going to pay it back through inflation that's going to be created by a Federal Reserve that prints money to cover our inability to borrow money in the future. So I believe pharmaceutical companies ought to have to publish their prices. How many of you know what the kickback clauses are, gag clauses? In the pharmaceutical industry, there was a bill that just recently signed by the president and passed in a bipartisan manner, eliminating gag clauses at pharmacies. And what a gag clause it says is I'm a drug company, I'm going to not allow you to tell the patient what the best price is on this. And if I'm a middleman pharmacy provider, I'm going to write a gag clause where you can't offer them that they could buy it cheaper if they didn't have it on their insurance. Here's a true story. We're getting ready to come out with a documentary, a group of us that are working the country on health care. Here's a true story. A prescription was written for 4 weeks of a new medicine, cost $469 with insurance by an individual, and she wanted the whole month that month because she was going to Hawaii for a vacation. She got to Hawaii and decided to stay 2 weeks extra. When she got to the pharmacy there, which was a local non-chain pharmacy that didn't have a pharmacy benefit manager, no agreements with them, she was told she could buy another 4 weeks of it for $49. So think about the conflict of interest in healthcare when it's about profit, not healthcare. When it's about middlemen taking money out of the healthcare system with no benefit. That's a pharmacy benefit manager who actually made her pay $469 or $49. That's who made her pay that. And had she been able to have the information at the pharmacy where she bought the original prescription, she could have bought it for $50. So we have untoward incentives in healthcare, and that's just one of many. The self-referrals inside hospitals, because they get reimbursed at a higher rate under Medicare than somebody outside. Do you all know what a certificate of need system is? Certificate of need is present in 25 states right now. And what it says is you have to prove to the state, if you want to compete in any area of healthcare, that there has to be a need for you to be there. And what it is really is a way for the, I don't think that was me. What it really is a way for those involved in healthcare to protect themselves, to make sure they don't have competition. And actually, Brookings has actually written on this in a paper in May of 2017, which said certificates of needs ought to be eliminated across the country. They gave 8 recommendations on how you could actually lower healthcare costs, and one of those is price discovery. In the Affordable Care Act, there was a section in there put by the American Hospital Association. Somebody doesn't like what I'm saying. It may be the pharmacies. Well, there is. I'm from Oklahoma. In the Affordable Care Act was a provision that said no longer could hospitals be owned by doctors. Now, wait a minute. Hospitals own doctors, but doctors can't. How many of you all knew that? So here's the thing. The Federal Trade Commission says the best outcomes at the lowest price across the country are in hospitals owned by doctors. Why is that? Because they have an inherent conflict of interest to have better outcomes, because it hurts them if they don't, and to control their cost, because it hurts them if they don't. So there's an example of that in Oklahoma City called Oklahoma Surgical Hospital. And I would suggest you go online and look it up. They publish all their prices. They publish all their outcomes. They guarantee their outcome. They compensate you if you have a complication. So I'll go back. Would we not be better off incentivizing and rewarding excellence in healthcare? I mean, we do in every other area of our economy except education. Education and healthcare is the only two areas of our economy where we don't utilize market forces to allocate scarce resources and enhance quality and punish and diminish incompetence. So the average cost to bring a new drug to market, and by the way, I'm not a fan of pharmaceutical industry. Although I'm taking their drugs, I love what they've done for me. They've kept me alive 6 years that I shouldn't be alive. But I'm not a fan of the whole system, because the whole system now is all geared to making money, not saving lives. So the average cost for a new drug is $2.6 billion. I want you to think about that for a minute. That's fully absorbed cost. That's all the other chemical moieties that they put together. The ones that didn't pass safety get canned out. The ones that failed stage 2 trials get canned out. The ones that finally get into stage 3, the average cost is about $2.6 billion. And we have a problem in the pharmaceutical industry because the patent starts is when they patent it, not when they get it approved. So now you have what is normally a 17-year patent life squished down to maybe 5 or 6 years. And they're sitting there, how do we make our money back over 5 or 6 years? So one of the proposals I think that there ought to be is there ought to be a patent extension based on what your original time was versus when you have approval. And that way, and then limit that, spreading that out to say the market forces here, you can't come in and jig it for another 10 years. You can spread that cost benefit over the remaining life of what would have been a patent. We do wonderful research. 55% of all breakthroughs in all areas are in this country still. A lot of them in the Northeast. Some of you will eventually someday be associated with that, and has made a tremendous difference in people's lives despite their tremendous pricing. If you think about it, take hepatitis C. The first drug that come out for hepatitis C to cure it cost $80,000 for a treatment. There's 3 drugs out now, it costs $20,000. Now, if you have hepatitis C, you're guaranteed you're going to get hepatocellular carcinoma. You're going to get cancer of the liver. So for $20,000, we can eliminate a virus from your liver and your body. And if you think about the productivity that comes from that, that's probably not a bad deal. But what allowed it to be 20 was competition, right? There was a third drug. The second one came out at 40, and the third one came out at 20. And another one will come out, and it'll be $8,000 or $9,000. Which in terms of what the benefit is a tremendous value. So what we have to look at is cost benefit. What we have to look at is regulation. What we have to look at is patent. But most importantly, what we have to have is an open market where you as a consumer can see what you're buying, see what you're paying for it, and make an assessment by looking online. What are the outcomes? What are the side effects? What's the cost benefit? And oh, by the way, is this the best price to compare it? Because what we have is all the reason 20% of our GDP is tied up in healthcare is 4% of it is middlemen making money off your illness that add no benefit whatsoever. You know, I think pharmacy benefit managers are an oxymoron. What they do is it's pharmacy benefit make us money, not manager. And so what we have is a conflict of interest between that group that the pharmacy hires to, and the insurance company hires to manage your benefit, and what price. And the price is unbelievable if you'll just look at the companies that do that and look at their PE ratios and look at their invested capital and the return on invested capital. It's outrageous. Versus the pharmaceutical companies whose invested capital is much higher as a percentage of what their return is. And so therefore their return on capital is much lower. So I don't think we have any problems in healthcare we can't fix. And I think we ought to have a system where nobody loses their job or their house or goes bankrupt because they have a health care. But I also think we can do that in a way that doesn't put a government person between you and health care. And the way to do that, I think, is to have a national, and this is my thought, this is Manhattan's, a national catastrophic plan to where nobody falls through, so that we have super insurance for those that hit the hard thing. And by the way, that's a small percentage of our illnesses. Most of our illness costs are associated with my age and older in death and dying. If you go look at the numbers where most of the dollars are spent. I actually have a do not resuscitate. I wear a chain around my neck that says, EMT, get there, don't you resuscitate me. I don't want to be resuscitated. The point is most family members, and I'll just give you a little aside so you'll know. I had about 25,000 patients, and I took care of everything from grandmothers to newborn babies to setting bones to doing gallbladders to you just name it. I trained as a general surgeon before I did family medicine. But I had relationships with my patients, and I knew what they wanted. And most of them, I got them to talk to me and have an advance directive. But here's what would happen, is they were in extremis, they were going to die, and one family member would come up and say, you got to do something. I said, they didn't want it done. You got to do something. I said, well, I'm not doing it. They said, well, we'll get somebody. I said, that's fine, but I'm not going to hurt your granddad, and I'm going to follow his wishes. And so about a third of the time, they would fire me and get somebody else. The ultimate result would be the same about 5 or 6 days later. Never had anybody that recovered from that. But the point is that was $180,000 more later. So this idea of how we deal with death in America and the confusing emotions that go around that have a big impact on the cost that you as young people, with a few exceptions in this room, sir, will be paying, because you're actually going to pay the bill for it. So I believe we can change things. I don't think we can change things through the factionalization that we have in our country today. But if we had real leadership that was about bringing us together rather than dividing us apart, that we could actually create a catastrophic health system, and that we could actually have transparency in pricing. And once you have transparency in pricing, you know what the next step happens? Is you get differentiation on outcome. Because once everybody publishes their prices, the next question a real consumer says, well, what about your outcomes? You may be cheaper, but are your outcomes worse? Or your outcomes better? So what happens is once you have pricing, you'll see fairly similar pricing, and it'll be below what we see today. But then you'll be able to decide based on what the outcomes are. And so if you're not in an emergent situation, and because your insurance is paying, you don't ask what it's going to cost. You know, if you got a copay and a deductible and you got a way to get that paid for, nobody asks. But once the prices are out there and say, well, you know, this doctor over here, like in the Oklahoma Surgical Hospital, they're 45% cheaper. 30% of their patients, you know where they come from? Canada. 40% of their patients, workers' comp from all across the country. And then the remainder are Oklahomans that want a good deal that don't have great insurance and say, hey, this will lower my copay, this will lower my costs, I'm going there. And because they can't compare, they have excellent outcomes. Again, I tell you to go look at their outcome, their website. You'll see what their outcomes are. So I'd leave you with the following 2 or 3 points. Markets work. They're not perfect. We don't have a market in healthcare in our country. That's one reason it costs so much. Number 2 is we ought to reward excellence. And you can see the opposite of that in the VA hospital system. Do you realize I don't know what percentage it is. A large percentage of VA doctors don't have a medical license. They've lost them. But if you work for the federal government, you don't have to have a license. And the 4th thing is greed conquers technologic difficulty. I want you to think about that for a minute. The desire to make money oftentimes results in tremendous breakthroughs, tremendous improvements, and we've not applied that to healthcare as far as the patient's concerned, because there's not a reward. What is in hospitals is a patient satisfaction survey. Anybody ever had one of those? All right. That asks you how they treated you, right? They didn't ask you, what were your costs like? What were your post-op complications, your post-hospital stay complications? What was the overall quality assessment of the care? Not of how, whether people were, it's basically a feel-good thing. What was the actual facts surrounding your care? Well, you didn't know. You couldn't assess it, and therefore they don't ask. But if, in fact, outcomes and prices are published, then all of a sudden they'll be educating you why they're doing what they're doing. You know, if I'm 65 years old today, I want somebody going to the hospital with me or to the doctor's office to get through this menagerie of care, which is put up by the insurance, medical. It's hard. It's hard to understand everything. So what I'm proposing to you is transparency in pricing, and market forces will markedly eliminate that. Final point. Medicine isn't just about science. 40% of medicine is art. The Affordable Care Act is killing the art of medicine. And let me tell you why. There's a mandate for computerized medical records, right? Electronic health record. When you're in with a doctor, and anybody that's ever had this experience, raise your hand. You're young, so most of you haven't seen many doctors. If they're spending their time looking at a computer screen, they're not spending their time looking at you. And what I was trained in medical, I was known as Grandpa in medical school because I was so much older than everybody else. But what I learned in medical school is you learn more watching the patient than what they say. And that is a fact. And the fact that the government has no authority to practice medicine but has changed the electronic medical record to where your doctor sits and looks at a screen instead of you. And I can find out more about you by asking prompting questions and watching your respiratory avoidance signals and your body language than I ever could having you fill out a piece of paper and me looking at a screen. So by not looking at me, you're getting a bad deal. So when you go to the doctor next time and say, would you turn that computer around and talk to me instead of the computer? Because you're going to learn a whole lot more watching me and asking me questions and seeing my physical responses that are nonverbal than you ever will by looking at that thing, except they get penalized if they don't. So I think we have problems that we can solve. I think we need leadership, but I think we need to go back and trust what we've used in almost every other area of our country, which is market forces to allocate a scarce resource. And I'd love to have some debate on that, or some questions on that, or some disagreement on that. And we've got a wonderful young lady up here who's going to have a microphone for you to participate with. Thank you.
Wonderful. Well, I wanted to start off by just saying thank you so much for this wonderful talk. I think it was very informative. And start off the questions by asking you, firstly, you talked a little bit about end-of-life care, and I was wondering, are other countries handling end-of-life care in a different way? For example, in Europe, do you know of different countries and different healthcare systems that kind of take the same approach that you do, that say at a certain point, listen, the outcome's not going to be different if you spend X amount more money, and so they reach a point of terminal illness where actually the doctors have the prerogative to step in and make that final decision, or are most countries kind of in line with the U.S. in terms of end-of-life care decision?
Well, maybe I didn't phrase it well. The individuals make the decision. You know, my biggest problem where our country is today is who gets to decide what. And when I'm at Berkeley, I ask them who should decide. They say we should. And if I'm at Oklahoma State University, who should decide? They say we should. So the question is who decides? And so having that relationship with a senior patient, knowing what their desire is as they get old, they decide that. They write out an advance directive, and they're the ones that make that decision. In Europe, a lot of countries, Holland, you can be euthanized if a group of doctors think you should be. It's not end of life. It's actually taking your life. So it depends on where you are. In most of the nationalized healthcare systems, in our country, if you break your hip and you're 85 years old, they'll put a new hip in you. In England, you can't get a hip at 85 unless you go outside of the National Health Service and ask for somebody to do it for you. And you may have 5 or 10 years of life expectancy, but somebody else has decided that for you. So I wouldn't go so far as to say somebody else ought to decide that, but I think we ought to have a national conversation that we're not afraid to talk about end-of-life issues so that people will be incentivized to make that choice for themselves before they get in that situation.
Please note that the microphone is for the camera, so it is on. You don't need to worry about that. Questions from the audience?
Thank you, Brigitte, and thank you. My question is, how can we do a slightly better job of extracting returns for these very expensive drug developments from other countries around the world, specifically Europe, and then places that don't even try, like India, who's decided it's too expensive for them, and base their healthcare system off stealing our patents for the most part.
I think that's a great question. I've told people in the executive office building that if I were dealing with Canada, they tell us what they're going to pay for our drugs. I'd say that's fine. We're going to tell you what we're going to pay for your lumber, and we're going to tell you what we're going to pay for your oil. So if you want to decide what something's worth that doesn't have anything associated with the intellectual value associated with it, that's fine. We're going to treat you the same way you're treating our drug companies. Same way with Germany. Germany gets a third less cost that you all are subsidizing. They're one of the wealthiest countries in the world per capita, and yet because they mandate that we'll only buy it. There's another problem, and it's really good that you at Yale would know this problem. Part of the problem is the lack of courage of CEOs to stand up to say, I'm not going to take that. I'll lose $50 million in revenue this year to not be extorted by your country telling me that my intellectual property is not worth it. So you can't have my drug. And that's the other problem, because we've walked into this with no true genuineness of purpose to saying a free enterprise system only works if you don't get extorted. And if you're willing to get extorted, it's not going to work. And what happened is that's exactly what's happened over the last 50 years. So it's a great question.
With the publishing of prices and transparency of prices of procedures and drugs, how do you propose to prevent insurance companies from blocking different procedures, since so many procedures have to be approved
Well, they
by
do it
drug
now.
companies?
They block your procedure. If they don't think you need a procedure, you can't get it if they say, no, you're not eligible for it. I mean, one of my biggest frustrations as a practicing physician, this is a true story, Blue Cross Blue Shield. 3 different times I told them one of my patients had a brain tumor. They said, you don't have enough data to order an MRI. So what do? I go to my friends at the hospital and say, will you do this MRI? Gratis. This guy's insurance won't cover it. I think he's got it. When it's covered, they'll pay for it. Sure enough, glioblastoma, multiform A, boom. Insurance. Second time, less than a year. I need to do an MRI on this individual. Their personality has changed. It's all soft signs, I agree. They got a brain tumor. Nope, you can't do it. Boom. I'll tell you about the irony of that. Sure enough, brain tumor. Third one, I call up the chief medical officer for Blue Cross Blue Shield in California. I say, if you deny this one, I'm suing you. That guy died 9 months later from the same disease that I diagnosed that they'd refused 3 times. So irony of irony is the person who has hands on a patient ought to be the person making that decision. Now, are all doctors good and efficient? No. But if in fact you reward outcome and price based on physician and publish their utilization rate for unnecessary tests, all of a sudden you'll say, I don't want to go to them. They're ordering tests I don't need, right? So once you have free market principles working in healthcare as far as outcomes and quality, then all of a sudden you're going to be able to make a more informed choice about where you want to go and subject your body to some of the most personal things that can happen. You want to make sure that person has excellence, that person is efficient, and that person is right.
So I have a question about the publicizing outcomes, what, if any, limitations need to surround publicizing outcomes? Like, for example, would doctors become more hesitant to take on riskier patients because they believe it could hurt their numbers? Or would a new doctor be very hesitant to take on risky patients because he doesn't want to have his numbers torpedoed by a small sample size in his first year?
That's the practical side. The question is, it goes back to one of virtue. Why are you a doctor in the first place? Are you there to care for people? Or are you there to have a reputation? Or are you there to make money? And so what we've seen is some changing in that since I first came into medicine, is that it sometimes isn't about virtue and isn't about caring for other people. It's about money. And so is that a downside? Yeah. But let me tell you something. The downside's worse now. You know? The fact that you don't know. I'll tell you another example. This is a corollary. I was head of quality assurance in our hospital for 3 years. I stopped 2 orthopedists from doing back surgery. Both of them sued me. I didn't want them to stop doing it. I just wanted them to have a complication rate that was in the normal range. And they didn't. So you don't know that now. So you don't know that the person you're going to may have the worst record in the world. But you don't get to see it. So the question is we ought to limit incompetence and reward excellence. And if you don't see outcomes, you're never going to see that. And guess who knows? All the doctors know who the bad doctors are, right? But you don't. Why shouldn't you get to know that? You know, not everybody that graduates from medical school is really good, right? They're all called doctor. But that doesn't mean they're competent. And so not having that information when you're putting your life in their hands, same thing with the anesthesiologist. Why shouldn't you know what their outcomes are, what their complication rates are, how many people have died intraoperatively under their care? Why shouldn't you know that before you go? You just trust? So you don't know what their outcomes are, you don't know what their quality is, and you don't know what it's going to cost you, and you don't know what's coming out of your pocket. You wouldn't do that anywhere else in the market today. How many have bought a new cell phone last year? Did you look at the quality factors on it? Did you look at what the storage was? Did you look at the guarantee? Did you look at the price? Yeah. So why wouldn't you apply that to something that's far more important in your life? Why wouldn't we use quality and outcomes and price to make a decision about who takes care of us? And what I'm saying is, it's not all that hard. And by the way, your generation is going to save trillions of dollars if we do. Because you're paying for it.
Yeah. So you had mentioned earlier, you're not a fan of high drug prices.
No, I'm a fan of return for intellectual property.
Yes. Okay.
All right.
So I guess then the question I have is, you would discuss competition in the marketplace and how that in turn can drive down prices for the consumer, right, and it's beneficial to us. But you would also discuss the extension of patent length. Mm-hmm. So for instance, if you're putting a drug out, you want your patent to last longer. So I guess my question is, the extension of patent length also kind of deters the development of generic drugs entering the market. So is that not inherently harmful to the consumer?
No, what I'm saying is, how many drugs today do drug companies not go on and spend money in because they're running near the patent life? All right? So how many drugs didn't come to market because a drug company made an economic decision, we're not going to put any more in this even though it's possibly a very good molecule, because there will be no cost benefit. I'll tell you, febendazole, you ever heard of that? That's a wormer for dogs. All right? There's good study that it's a wonderful anti-cancer agent. But nobody will spend the money to do a trial on it because it's a generic drug. So we don't know. But we have all these anecdotal responses of people with stage 4 cancers who got on febendazole 3 days a week, whose cancer's totally gone. Except we don't have any money, either from the NIH or a drug company, wanting to know why that is. And the reason is, it's because there's no cost benefit to it. There's health benefits to it, but there's no cost benefit. So all I'm saying is there's an opportunity cost that's gone because we don't have some reasonable way. And remember, patent life is determined really by the FDA, not by the person owning the patent. So if, in fact, there was some variable where you could say, okay, we give you 3 more years if it took you 4 years inside the FDA, right? Or we give you 4 more years. But some common sense so that we don't stop research on drugs that look good because there's no patent benefit to it, right? So that's the answer to it.
Any more questions?
Do you think it would be helpful to increase the competition not only at the medical care level but also at the insurance level by ending the tax treatment of employer-sponsored insurance and putting more people on the individual market instead?
Well, what I actually think is they ought to be the same, one way or the other, because there's a tremendous, it's $280 billion a year is the benefit difference. I think I'm trying to recall that. Don't hold me on that number of what corporations benefit out of that individuals who buy in the individual market get no write-off from. What I think is there ought to be real insurance, and there's not. I don't know if you all saw, about 6 weeks ago, Blue Cross Blue Shield of California had $24 billion in the bank, and yet was raising rates. Now, that's a non-profit insurance company. The non-profit hospitals in America made $56 billion last year, the non-profit hospitals. In Florida, 30 days after an indigent is there, they file a lien on their home, so they can't sell it until they've paid off their outrageous bill. So I think what we ought to do is go to high deductible with medical savings plans and allow you to pay for your deductible and your co-pays out of that and your insurance and give you a tax write-off. And then you can have a high deductible if your income allows you to do that. And if you don't want to have a high deductible, you can pay a higher amount. But, this idea of reinsurance against your copay, you know what all that does? All that does is give peace of mind to seniors. But it's a racket. It's a racket. If you go take the average senior and look at what they're paying for their, I'm trying to think of the word, their supplemental policy, and you take all their bills that year, they're getting hosed. On average, they're getting hosed. And United Healthcare and AARP are making a fortune off of it. And by the way, AARP gets something like $250 million a year tax money anyway, every year. And they're making another $500 or $600 million off of that alone. So I just think insurance is really prepaid expense for which you pay a great deal of money to have them pay your bills. And then they're telling your doctor what they can and can't do. One of the reasons I stopped medicine, when I left the Senate, I continued to practice. And I quit because I was tired of telling somebody who had no education near mine, who'd never laid their hands on my patient, what I could and couldn't do with my patient. Because they were sitting in an insurance office and didn't know what they were talking about. But they had an algorithm that they were supposed to go through to decide whether or not I could do what I needed to do with my patient. And so that's the kind of health care we have today. It's not your doctor practicing health care. It's your insurance company practicing health care based on what you can and can't do. And so if we went to high deductible plans where you could actually have an encounter in the healthcare field before you got seriously ill so that they could actually do what they need to do without saying, "Mother, may I," to a clerk at an insurance industry, we'd probably have much better outcomes than we do today. Couple over here. Go ahead.
How would the high deductible plan work for lower income families who couldn't necessarily afford much of anything in regards to their expenses?
What you do is have subsidies to help them.
Okay,
but
so
here's the problem. Here's what I hear all the time from patients. It's okay. It's just my deductible. I've met my deductible. It's just my copay. I'll just do it anyway. So there is no market-making choice because we've sucked them into thinking, oh, it's paid for anyway, right? You know what the busiest operating day is in the United States? December 30th. You know what the slowest operating day is in the United States? January 2nd. Deductible's been made. I want to get it done before the new year starts. Deductible hadn't been made. Nobody wants to get operated on the 1st of January, 2nd of January, right? And that's backed up with facts. So what you can do is you can, based on income, you can say, here's how much tax advantage you get out of this. Here's the thing, is we don't allow rollover. We don't allow you to pay out of that. And a high deductible for you may be $700 or $800 versus somebody else. Do you realize when I got out of Congress, after I was there 6 years, I came to Oklahoma, and I wanted to buy for my employees. I had 36 employees, 4 doctors, 36 employees. It's a lot of employees. Most of that was insurance and government work. I wanted to buy $10,000 deductibles for both of them, for all of them. Couldn't buy it because the state of Oklahoma wouldn't allow the insurance company to sell it. But found out later the insurance company had lobbied. We don't want to sell that. So please don't approve it. Because that means people will actually be making decisions based on what the costs are rather than relying on us. We want to remember what insurance is. True indemnification spreads risk, right? Health insurance is not true indemnification. Insurance companies make more money if costs go up. Think about that for a minute. They have no incentive to lower costs because the next year their premiums go up based on what their experience factor was. So it's the reverse of true economics in terms of, is it insurance or is it prepaid expense? And what I would put for you most of the time, our health insurance is prepaid expense for which you're paying a hefty premium for them to pay your bills. Yes, sir.
One moment, just for the camera.
Thank you. You are so brave to undertake a project that is so amorphous to most of us. And I need to know from you, and I'm not being disrespectful when I say, is a practical way for me, and if I were 70 years younger,
Well, you'd be a baby if you were 70 years younger.
But I might know as much as I know now. I know so little, and it's so hard to quantify. All the doctors I have, say I have 5 doctors, 3 of them are very personable and 3 are passable, but none of them have ever brought up the subject of what medicine costs. And none of them seem excited about undertaking doing something about it. I'll stop talking now in 15 seconds because I don't know. This is such a big, broad subject. There's no way for you to motivate me and kick me in the tail and say, get out of here and go do this, this, and that. Would you tell me the answer, please?
Sure. It's called direct primary care. The answer is there's 2,600 doctors that have opened these in the last 2 years. You go in, the average adult pays $100 a month. The average child is $50 a month. Everything's covered that can be covered. And they provide your drugs at their cost plus 10%. So instead of you going to a drug, you walk out with your prescription when you leave at about 1/10 the cost when you go to CVS or one of the others. You got your drugs. You didn't pay anything extra because you'd paid your $100 a month, and you can come as many times as you want. And so what's happening is you're seeing this transition by the primary care doctors in this country to direct primary care because they're tired of talking to insurance companies. They're tired of working with Medicare. They're just saying, here's what we're going to do. This is what it costs. If you're on Medicare, we don't care. It's your cost. You come in, we'll take care of you. We're not running an invoice for anything. We're not billing anything. That's different than concierge care, all right? Concierge care is like $500 a month or $350. This is direct primary care that says we want to care for people. We want to get back to looking at the patient. And, you know, by the way, a chart in my office in Muskogee, Oklahoma is a whole lot safer than your medical record on the internet. But we mandated that you got to do it. One little side point. Do you all realize that IBM offered the federal government Mayo's medical record program for the whole country, and that they would maintain it for the next 25 years for free? They turned it down. Now what do we have? And why did they turn it down? Because everybody that was in the business of trying to sell computerized medical records wanted theirs to be in the deal, right? So now we still don't have any communication across the country. You still can't carry a smart chip in your billfold that goes to any doctor and put it in there. They know what you're allergic to, know what your past medical. None of that's available because we chose not to take a very generous offer from a big corporation who'd already figured out electronic medical records. And so what have we spent so far? $100 billion on useless electronic medical records because they can't communicate. And if they don't communicate, they're not of any benefit other than making a doctor, when she's sitting there talking to you, looking at a screen instead of looking at you. And by the way, your friend was having a lot of body language problems. They're uncomfortable with a lot of what I said.
Beyond just like greater transparency in terms of outcomes, what do you think is the best way to balance legitimate malpractice claims against requiring doctors ultimately feeling compelled to do a lot of unnecessary tests because they're worried about malpractice suits?
Well, it's called tort reform. My last year, not my last year, 4 or 5 years before my last year, I paid $80,000 a year. When Oklahoma passed a limitation on pain and suffering at $300,000, my malpractice went to $22,000 a year. So all you have to do is get the influence of the trial lawyers out of the State House and pass some common sense malpractice tort reform. And we didn't just do it in Oklahoma on health care. We did it on everything. So if you truly have an injury, you should be compensated for it. The idea of pain and suffering is to punish somebody, right? It's not about benefiting the individual, it's about punishing somebody. So if you have tort reform, you will solve that. There's another way to do it. Do you realize most trial lawyers, when you have a malpractice claim, go to a claims agency to find out what it's worth? Then they tack on 35% to what it's worth and file your suit. Now, that's a conflict of interest under the legal profession's own guidelines. So if you would take that away and start having lawyers practicing law instead of picking your pocket because you had a bad outcome, we'd see a difference. And I was only sued once, never on an obstetric case, and I won it. As a matter of fact, got kicked out of court. The reason you get sued is because you don't have good relationships with patients. It's the reason you're a good senator is because people trust you. It's the reason you're a good doctor is because people trust you. And when you have miscommunication because you're looking at a computer screen instead of talking to the patient, you're going to get sued more often. Good question, by the way.
Do we have any more questions?
You get to go home. Or maybe you get to go study.
All right, well, seeing no final questions, I just want to say a big thank you for coming and speaking to us today from the Buckley program.
Thank you.